Um, Dr. Anna Chacko is a radiologist of great distinction and renown. I met her last year at RSNA for the first time, and I feel like I've already known her a long time. She grew up in Hyderabad, where she attended the Osmania Medical College and won every medal possible in the course of her studies there. Subsequently, she moved to the United States, where she trained in radiology, in nuclear medicine, and in internal medicine. So she is triple boarded. She's also done fellowships in sports medicine and in MRI. So her academic training is beyond compare. Dr. Chacko is widely regarded as an exceptional educator. She has worked as professor of radiology at the University of Pittsburgh and at Boston University, and currently resides in the beautiful state of Montana in the western United States, where she is chief of the hospital, chief of radiology of the hospital there. Dr. Chacko is a radiologist with an exceptional social conscience. She is very active in terms of writing, and she's had a very long and distinguished career with the United States military. So, and has been awarded numerous times by the military, including the Legion of Merit. I was interested to learn. We're very honored and happy to have Dr. Chacko speak to us this evening, and she's going to be speaking to us on the topic of the posterior cruciate ligament, a radiologist's view. Thank you, Dr. Chacko, and it's over to you.
Thank you very much. Can you hear me okay?
Yes, we can hear you very, very, very clearly. Thank you.
Great. I was going to say good morning, but it's good evening to you. I want to correct one thing. At this point, I'm sitting at home preparing lectures for different people. I'm not working at the hospital, partly because of personal issues with my family. But it gives me great pleasure to speak to you, and I'm so grateful to Arjun for providing me with the opportunity to speak to a bunch of radiologists and also to keep my reading and learning current. We can start with the posterior cruciate ligament, and let me get used to moving the cursor around. The knee is a pretty complex joint, and it is the largest joint in the body. I would have thought it would be the hip, but it really isn't. And the problem with the knee is the body weight is carried on a very small surface area of bone, and it's anatomically very complex and vulnerable to injury. So the problems, if they are left unattended within the knee, they don't become easier with the passage of time. That was a quote from one of the orthopedic surgeons who trained me during my fellowship, which was last year. I took on a fellowship in orthopedic and sports medicine MRI research, and enjoyed it thoroughly. Now, analysis of the derangements of the knee represent a major part of the clinical practice of multiple medical specialties. And for us as radiologists, it is critical that we are able to appreciate what the orthopedic surgeon or the physical therapy person sees and is interested in. Now, the cruciate ligaments are our topic for today, and among the other structures are designed to protect and stabilize the joint. But because of the tremendous risks that are involved with using the knee, they're a frequent source of pathology as well as of pain. What we will start off with is evolution and embryology, and then the function of the structure under question, and the diagnostic imaging techniques. Now, the human being, when you compare the knee joint of the human being with other animals, we find what is absolutely different with the human being versus the animal, which is that the knee is plantigrade. The human being is a species that is plantigrade and biped. Now, what does that mean? It means that most of the animals are quadrupeds, and they also walk on the balls of their toes rather than the entire foot. Now, what that does is it places different strains on the joints involved, and the complex attributes which are associated with the human knee involve a bicondylar distal femur. We have two condyles separated by the intercondylar fossa. We are the only species with intra-articular cruciate ligaments, menisci, and collateral ligaments which are asymmetric. But here is the most important point. The greater femoral rollback of the lateral compartment produces greater strains compared with the medial compartment. Since the lateral compartment or the lateral condyle of the femur has a greater area than the medial, once the medial gets into position, then there is further rollback of the lateral condyle on the lateral surface of the tibia, producing the locking mechanism, which can go severely wrong and produce strains which wouldn't happen had they been symmetric. Now, the limb buds are formed from somatic mesoderm covered by an ectodermal layer. There's a dorsal ridge-like elevation in the fourth week of intrauterine life. The development of the knee is first seen at 6 weeks with the appearance of femur and the tibia. Then there is chondrification of femur, tibia, and patella with the formation of the patella tendon. The collateral ligaments appear at week 7, medial meniscus at week 10. The joint at that time is a single cavity at week 12, and the suprapatellar plicae start forming, producing the different compartments of the knee as we know it. Perichondrium bridges across the limb segments and is transformed into a capsular ligament. Anteriorly, it becomes a quadriceps tendon, and posteriorly forms the posterior part of the capsule. As the condyles of the femur develop and grow towards the popliteal space, a portion of the posterior capsule becomes isolated, remaining within the joint to become the cruciate ligaments. What does this mean? It means that the cruciate ligaments, although they are intra-articular, they're not intrasynovial. And why is this important? We will see that in just a few minutes. Now, flexion and extension of the knee are rendered more complex because there's a shift of the axis around which movements occur, which I had explained a few minutes ago. In both extension and flexion, the cruciate ligaments are taut in all positions of the femur, providing bonding between the femur and the tibia. The movements of rotation actually are very small compared with extension and flexion. These rotatory movements are divided into two types: adjunct, which occur independently of flexion and extension, and conjunct, which are part of flexion and extension. When you watch an orthopedic surgeon examine a knee, you will see that they try to rotate the tibia on the femur externally as well as internally. Ordinarily, while we are walking, this movement is barely perceptible. There was a study that was published by the British Journal of Sports Medicine, which may or may not be of importance to you. However, when I did my fellowship, it was an exclusive sports medicine practice. And the BJM said that there were 500 significant knee injuries per year in a population of 400,000 people. In India, of course, 400,000 is a very small number. Now, extrapolating this quoted number, this translates to more than one significant knee injury per day and an additional significant case every 2.7 days. Boland, who wrote this article, reported that 30% of the patients studied had been seen by an orthopedic surgeon. 28% had undergone an arthroscopy or arthrotomy without the diagnosis of ligamentous injury having been recognized. Why is this important? Because the procedures of arthroscopy and arthrotomy do not really lay the knee joint completely open unless we as radiologists caution or draw attention of the orthopedic surgeon to things that might have gone wrong. Now, the historical perspective on MR is in 83, Keene et al., and in 84, Lee et al. Defined the potential of MRI in the assessment of the knee. Subsequently, there was a huge deluge of investigations attempting to outline the role of MRI in evaluation of the musculoskeletal system, especially the knee. MRI has become the modality of choice for non-invasive evaluation of internal derangements of the joints, particularly the knee. In smaller practices or in practices that are not as wealthy as the research institutions or universities, MRI tends to be more expensive, but the manufacturers have started manufacturing the smaller orthopedic magnets, which makes it much more accessible, MR much more accessible to our patient population. Now, 30% of MR imaging is ascribed to the evaluation of musculoskeletal system. Now, with the development of PET MR, we will be seeing more advances in the study of disease and in the evaluation of treatment and its efficacy. Why is this important for us as radiologists? PET in nuclear medicine, particularly in India, is the sole province of nuclear medicine people. But with increasing frequency, the addition of other radiographic or radiologic methods of investigation are fused with PET, so that we need to be aware of what PET can do for us in the context of MR. This is not something we're going to discuss at this point. Higher field strength magnets provide higher signal-to-noise ratio, which is made possible also by using phased array coils. Smaller fields of view, thinner slices, and larger matrices, which were not accessible in the past, have now become accessible so that we can evaluate different structures. And surprisingly, tissue mineralization becomes much more obvious. Now, MR of the knee is the most frequently performed MRI examination, and after an initial study with plain radiographs, it has supplanted arthrography and arthroscopy. Now, there are some institutions which continue to do MR arthroscopy. Where I trained for orthopedic MR, we did not do arthrography with either saline or fluid of some kind or gadolinium. And the reason is that a lot of orthopedic surgeons believe that introduction of infection could be possible the more you interfere with the joint. And there was a significant body of investigation done by the University of Pittsburgh, orthopedic surgeons, who cultured chondrocytes in Petri dishes and exposed them to different solutions, including anesthetic, saline, as well as gadolinium, and found that introduction of any of these reduced a significant loss of chondrocytes. Does this translate into the live patient? They believe it does. So actually, caution might be the better part of valor. And what we can see is, looking at a joint that is injured, there is inherent fluid in the joint produced by the trauma, which allows us to look at the joint efficiently. In the hip, however, this may be a matter of concern. Now, all three planes should be acquired. Magic angle is a nuisance, and this can be avoided by triangulation. Using a dedicated knee coil will improve the signal-to-noise ratio, and as I mentioned earlier, a small FOV, or field of view, improves the spatial resolution and requires high field strength magnet. Now, fat suppression or fat saturation sequences are actually the godsend of MR, because they provide definition of abnormal fluid collections, looking at cysts or bone contusions and edema. Imaging sequences, the ones that we use are T2-weighted images, which are called pathology sequences. T2-weighted weighting can be obtained using either the conventional spin echo, turbo-fast spin echo sequences. T1-weighted or proton density-weighted images have very high signal-to-noise ratio and are referred to as the anatomy images. These are used to detect fine details, such as with tendons, ligaments, and menisci. Fat suppression can be obtained using either spin echo or stir sequences. Stir sequences actually are more useful when there is degradation of the image from susceptibility artifact from hardware. Proton density-weighted imaging with fat suppression shows the PCL contrasting with the high signal intensity of fluid which may be present. Here is the proton density. Hang on a sec. Let me just get this right. So here is a proton density image, and you can see that the resolution compared with the T2-weighted is far better. However, the T2-weighted image allows us to see the fluid beautifully, outlines the cartilage, and also shows us where there is an avulsion of the posterior cruciate ligament, producing edema of the underlying tibia. Now, what about stir imaging? This sequence, as I said before, minimizes the artifact from hardware, and it is used in lieu of the standard fat suppression sequences that we use most of the time in our imaging protocols. It enhances tissues with long T1 and long T2 relaxation times, and is useful when you're trying to differentiate signal from bone marrow versus signal from intramedullary pathology such as tumor. Here is a good example of a stir image showing bone contusion from a direct blow on a dashboard injury. Now, the posterior cruciate ligament, there is a rising interest in the PCL, most likely because there is a rising incidence of injuries. This may be because of competitive sports as well as recreational athletics across all age spectra. A large percentage of PCL injuries are not diagnosed in the acute setting. In the place where I did my fellowship, patients who were examined in the emergency room and referred to the orthopedic surgeons actually came directly to MR before they even had plain radiography. Is this advisable? Remains to be seen, but that's what we did. Far more has been written about the anterior cruciate ligament than the PCL, and there are several features about the PCL that set it apart from the ACL, which is it is several folds stronger than the ACL, having a greater tensile strength. The PCL, because of its location, is less susceptible to injury, which means that when the PCL is actually involved in injury and is injured, the force which produced that injury is significant compared to a solitary or isolated ACL injury. Now, PCL is less accessible to arthroscopy than the ACL, and therefore it is more difficult to assess clinically. Very often, orthopedic surgeons who go in with arthroscopy don't give much attention to the PCL because it's way behind in the back of the knee joint. These may all be contributing factors to the fact that there is a lack or paucity of literature compared with the material on the ACL. Remember, I had talked about how we would address these different issues. We'll first look at the anatomy, then at the function, relationship to other structures, MRI appearance of normal PCL, MRI signs of PCL injury, and abnormalities of the PCL in association with and as secondary signs of injury to other structures. The thing with joints, which is so beautiful, is that when you see an abnormality in one structure, it immediately points to or cautions you to look for other injuries which you may not have looked for if you were just looking at one isolated structure. Varying opinions exist on the composition of the PCL. Now, why is this important? Because the two bundles, the anterolateral bundle and the posterior medial bundle, have slight differences in function. The anterolateral bundle becomes taut in flexion and slack in extension, where the posterior medial bundle is the opposite. Now, can we resolve these on MR? No, we cannot. But it helps us when we are questioning the patient regarding the mechanism of injury to see which might have been injured, so that while the PCL may not be completely injured, you're still aware that there may be a partial injury. Now, one of the most important factors that you have to pay attention to is the thickness of the posterior cruciate ligament, which is about 38 millimeters in length and 13 millimeters in width. Why is this important? Sometimes you may not see an actual disruption of the PCL, but the fact that it is wider than 13 millimeters should caution you that there may be some injury with the PCL. Now, is this an absolute measurement? Actually not. With bigger people, I'm not talking about fatter, but bigger people, the 13 millimeter width may not be quite applicable. But for the average human being, the 13 millimeter width is a good standard to go by. Now, the orientation of the two bundles, as you can see, is that you have the anterior, when the knee is flexed, the anterolateral is up here, and the posterior medial down here. As you look at the extension, you'll find that they switch in location, which tells you why they become taut. Now, remember I told you that during embryology, or embryologic developments, the anterior and posterior cruciate ligaments are intra-articular but not intrasynovial structures. Why is this important? Let me tell you why. If you look at your diagram on the right, or on my right, you will see that here is your anterior cruciate ligament, here's your posterior cruciate ligament, and there's a triangular area which generally doesn't have fluid. If there is fluid in that, particularly when you're looking at fat suppression images or T2 weighted images, you'll find that if there is fluid between the two ligaments, the immediate conclusion is that there has been a disruption of the synovium so that fluid leaks out into this triangular space. The femoral insertion of the PCL is along the lateral aspect of the medial femoral condyle. Girgis is a very, very prolific author and has written some phenomenal articles, even as far back as 1975. If you can get a hold of this article, I would recommend you do and keep it because it's a classic. This is the way the anterolateral and posterior medial bundles are oriented. The orientation of the PCL femoral attachment is antero-posterior, whereas the ACL is horizontal. The ACL is vertical, which leads you to understand why one ligament will twist around the other. The PCL twists around the ACL during movement. Now, the tibial insertion, the posterior medial bundle, is located in this location here, and the anterolateral right here. The tibial attachment is more lateromedial, although it's not obvious from the diagram. It's more lateromedial than anteroposterior. What is important about the attachment of the PCL? The PCL, as I mentioned to you, is a very, very strong ligament, and it goes through a zone of fibrocartilage to a second zone which becomes mineralized and goes on through to the bone. The fibrocartilage at the emphyses acts like a brake to the horizontal shortening of the ligament. Something else happens. Fibrocartilage is not expected to be present in the ligament, but sometimes you will find a nidus of fibrocartilage in the center of the ligament. This happens when there is chronic injury to the PCL. So if by chance you see fibrocartilage in the middle of the PCL, you know that there is a problem there, and it may represent increasing stress or strain on the fiber bundles of the PCL. Now, what about the vasculature of the PCL? Why are these things important? Because people usually don't pay attention to these structures which we as radiologists or glorified anatomists know really, really well. Now, please pay attention to the popliteal artery. And what does the popliteal artery do? It gives off, from its anterior aspect, the middle genicular artery, which then pierces the posterior end of the capsule to supply both the anterior and posterior cruciate ligaments. Now, this is important because this makes the middle genicular artery susceptible to injury, whether iatrogenic or because of injury from an accident or other endeavor. The artery is also known as the azygous articular artery, and this is something that we have to pay attention to when we're looking at an injured PCL. The lymphatics are very important because they serve a mechanical and a nutritional role, and the absence of basement membrane supporting the endothelial lymphatic cells provides permeability, allowing resorption of bacteria and other macromolecules. Now, why is this important for us as radiologists? When a patient undergoes lymphadenectomy, such as for a melanoma, where the deeper and the superficial femoral and inguinal lymph nodes are removed, the lymphatics are disrupted, and you will find that there is lymphedema, which makes the patient more susceptible to infection, and that should caution us that we should be looking for evidence of infection either in the form of septic arthritis or osteomyelitis. Now, there is something else that I wasn't aware of until I actually started doing my fellowship in orthopedic MR. It is that ligaments which, during my day of anatomy dissection, which is way back before most of you were born, is that we consider ligaments to be passive structures, but they're really not. They are helpful in proprioception. And the main nerve supply to the cruciate ligaments is the posterior articular nerve, which originates in the popliteal fossa and then enters the knee joint. And you know, we hadn't realized that there is a fine band called the intercruciate band, and between the anterior cruciate ligament and the posterior cruciate ligament, and these carry the nerves, so that nerves which mediate proprioception, so that there is inherent perception by the PCL and the ACL of each other's position. Now, you might be saying, why are all these things important? It is important for us to understand how a PCL can be injured. The PCL, as I mentioned earlier, provides restraint against posterior tibial displacement on the femur during flexion. Being positioned at the center of the knee, PCL provides central stability to the knee. All internal and external rotational movements occur around the central axis provided by the PCL, whether it's normal or abnormal. And we have talked about winding around the ACL, the PCL resists internal rotation of the tibia. Generally, the normal PCL is significantly different on MR than the ACL. Now here, you'll find that the ACL has some more signal than the PCL. PCL is pretty dark. Why is that? No one really knows. And we believe that this allows us to look at, or we use this feature to look at injuries to either ligament. Histologically, exactly the same. Now, despite the fact that they're composed of identical fibrous tissue, PCL, as I mentioned to you, is more hypo-intense than the ACL. Now, volume averaging effects related to the twisting of the ACL bands is one of the theories that is proposed. The mid-portion of the ACL is thinner in its substance, therefore increasing the possibility of volume averaging and giving it more signal than you see in the PCL. Also, there is fat stranding present at the tibial insertions of the ACL, which is not seen on the PCL. Now, what does the normal PCL and ACL look like? This is the normal PCL. Please note the position of the femur with the tibia. If you were to draw a line where the shaft of the tibia goes upwards, and you draw another line which is aligned with the shaft of the femur, you'll find that the difference between them is not significant, and definitely less than 5 millimeters. When the PCL is injured, when the PCL is injured, as I mentioned to you, the PCL provides posterior translation of the tibia on the femur. When the PCL is injured, the tibia slips backwards, increasing the posterior translation. So if you were to drop a line from the posterior aspect of the femur and compare it with a line from the posterior aspect of the tibia, this distance becomes significantly longer or larger. And that is a very subtle finding if you don't pay attention to it. Now, what are the multiple configurations of the PCL? You have to be acquainted with the multiple configurations of the PCL. The most common is a very, very gentle curve, which we see down here. Here is a nice gentle curve as seen in this picture. Sometimes it can be angulated. And please notice that I have drawn angles, and we'll come to that in just a little bit. Now, that is still normal. However, when the angle becomes more acute, as you're seeing over here, that is an abnormal situation, and it cautions you to look for injuries throughout the knee joint. Sometimes the PCL becomes hypobuckled, as you can see in the picture on your right. Sometimes it shows up with 3 limbs, which is also abnormal. So we see that the gentle curve and the Obtuse angulation are both normal, and the other configurations are abnormal. So here is a composite showing you all the different configurations that you expect to see. Now, when you are looking at this angulation, I recommend that you draw a line along the superior limb and another one along the posterior limb and calculate this angle. You'll find that it becomes, during abnormal situations, it becomes more acute. Now, what do you do when you're looking at an angle which may have three limbs? What you do is you do the best fit circle analysis, which is you take a circle at the lower limb and at the inferior aspect, draw a line upward, and do the same thing for the most proximal limb. This is the angle you will measure. When it's a gentle curve, it's fairly easy. You take something tangential to the superior limb, tangential to the inferior limb, and you measure it. Now, that's a joke. ACL does not come in 31 flavors. I don't recall that they have Baskin and Robbins, which is a huge ice cream vendor, and it's good for us that we don't have to remember 31 different ways that the ACL can manifest, just a few. Now, what are the primary signs of PCL injury? You can have a complete tear with a high signal in the PCL. Here we go, high signal. When there is a partial tear, high signal incompletely traverses the PCL. Okay, you can see that. Now, when there is a peel-off injury, you notice here how beautifully the PCL is opposed to the femur where it is not peeled off. Here it is peeled off, and you can see, hopefully you're able to see what I'm showing you. You can see it is peeled off from the femur. So that's an injury. Now, if we were to do a fat suppression image of this particular knee joint, you will be able to see the contusion or the edema in the bone marrow, which would draw your attention to the fact that there is a peel-off. Now, another thing that you want to pay attention to is if it is peeled off at the tibial insertion. Notice here that the PCL has higher signal than you would expect to see normally. Now, imaging injuries to the PCL. These are fat-suppressed images. Notice how the PCL is greater than 13 millimeters. Here we go. 13 millimeters, greater than 13 millimeters in multiple projections. In this projection, which is a sagittal, in this projection, which is a coronal, you'll find it's greater than 13 millimeters, which means that there is intrinsic injury to the PCL. This is easy, that even a blind man could probably see that the PCL is totally ruptured off and peeled off the tibial insertion and goes like a little spring into a coiled position. Now, injuries to the PCL, when you're doing fat-suppressed images, you can see the injuries to the PCL much, much better. So here we go. You can see that this should be nice and dark, and it isn't. Here you cannot trace the PCL completely, and you become cognizant of the fact that there is injury to the PCL. On the transaxial images, you don't expect to see signal in this area, but when you do, you know that there is injury to the PCL. Now, secondary signs of PCL injury, this is a misnomer, but because once you find the primary signs, why would you bother with the secondary signs? But in case you missed the primary signs, you look for the secondary signs. Bone marrow edema involving the anterior proximal tibia. And then you have avulsion of the posterior tibia at the tibial insertion of the PCL. There are associated soft tissue injuries which you must look for. Disruption of the ACL and hyperextended injuries, associated injury of the medial collateral ligament, and associated injury of the medial meniscus. There are grading systems which allow the orthopedic surgeon or whoever is treating the patient to recognize what is happening with the degree of injury and the gravity of the injury. These injuries to the PCL might be isolated or combined, and they're based on the degree of posterior subluxation of the tibia, which is something that I showed you here. Isolated injuries can further be classified into partial, grades 1, where the posterior translation is 1 to 5 millimeters, which is really within normal limits, and 2, 5 to 10, and complete tears, which is grade 3. Based on the degree of PCL disruption, you can also grade the tears, but you have to be specific how you graded the tears. If they're partial tears, it's grade 1. Grade 2 is isolated complete tear of the PCL. Grade 3 is when there is injury to other ligaments. 40% of injuries are isolated and therefore undiagnosed and have an excellent prognosis. Grade 3, when it is combined with other injuries, carries a much more ominous prognosis. The most common site of injury to the PCL is mid-substance. Femoral and tibial avulsions are less common. Femoral avulsions are more common than tibial because the femoral attachment is weaker and smaller. But when you're looking at the ACL, you'll find that the insertional injuries are more common than they are in the PCL because the attachment of the ligament to those bones is very strong, which adds to the strength of the PCL. You may recall that I had mentioned earlier that the PCL is a stronger ligament compared with the ACL. Now, Schultz, who studied 500 cases of PCL insufficiency and diagnosed and graded the PCL repairs, clinically diagnosed it using the posterior drawer test. Presence or absence of the tear was based on functional competency of the ligament rather than the presence or absence of tearing on imaging studies. And what they found in this was that the imaging studies were far better predictor of injury than doing a physical exam. Why is that? The reason is that a person who has acutely injured his knee joint, you cannot move it because of the tremendous effusion there is into the knee joint and a significant degree of pain. So this is where the imaging comes into play. When it's a chronic problem, you may be able to move the tibia backward and forward on the femoral condyles. But when it's an acute problem, you cannot. You also look for bone bruises. As I mentioned to you, look for the bone bruises. Here is a bone bruise. This should caution you that you're looking at a disruption of the PCL along with the ACL. Also gives you an idea of the mechanism of how it actually occurred. Now here is another bone bruise. You might recall that earlier in the talk, I had shown you a dashboard injury. So when you're looking at a dashboard injury, somebody sitting in the car expecting that everything was going fine, and then there is a sudden braking of the vehicle, and they knock the tibia against the dashboard, and you will see a dashboard injury. What does that do? It pushes the tibia backwards and may cause disruption of the posterior cruciate ligament with a femoral attachment avulsion. Now, bone fractures, avulsions, and edema, as well as the location of the abnormality, are related to the mechanisms of injury. When there are internal injuries to the knee, such as contact between the femur and tibia, you get a kissing type of bone marrow edema pattern. The ligamentous injuries where both internal and external forces are applied, bone bruises are in predictable locations. When PCL and PLC, what is PLC? It is the posterior lateral corner of the knee joint. When these are involved, bone marrow edema is noted in the tibia. Hopefully we will have some time to discuss, not at this present lecture, but the importance of posterior lateral corner. Now, I had not realized as a general diagnostic radiologist of the importance of posterior lateral structures, and it is important for us to know these because if we don't recognize PLC structure injury, the patient can have significant problems and development of osteoarthritis and instability of the knee. A reverse Segond fracture, PCL is which is associated with MCL injury, and there is an avulsion at the site of the coronary ligament, will present with reverse Segond. Look for tibial tubercle fractures and fibular head fractures. One of the interesting things that I learned while I was preparing for this lecture is in lower species of evolution, the fibula actually articulates with the femur rather than with the tibia, with evolving specialization and development of a bipedal stance. And with the animal standing up, the fibula migrates downwards and articulates with the tibia rather than with the fibula, carrying multiple structures down with the head of the fibula, and constitutes what I had just mentioned as the posterior lateral corner structures, which must be looked at. Now, meniscal injuries are relatively uncommon. When they do occur, the medial meniscus involvement is much more common. Tears of the anterior horn of the lateral meniscus and radial tears of the body of the medial meniscus are said to be characteristically associated with PCL injuries, which are grade 3. Meniscofemoral ligaments may be involved due to their close association with the PCL. And as I mentioned, the PLC structures must be looked at. MCL complex and or ACL abnormalities could form a constellation with certain PCL injuries. Now, what I have provided for you here, which I am sure that Dr. Kalyanpur will provide for you at your request, please feel free to look at all these articles that I have marked out for you, which what I looked at to produce this lecture. So we had about 60 of these. Now we come to the end of the lecture, and these tigers are saying, well, I'm glad it's over. You might be wondering why tigers, and I'll tell you a little story. When I was about 6 years old, my father, who was a very gentle, lovely person when we lived in Hyderabad, brought back home a tiger with him, and his explanation to my mother was he took it as a collateral for a loan that he had loaned somebody who had a tiger. So the tiger turned out to be a nuisance because it ate more meat than the entire household ate in one month. So my mother, of course, was very angry with my father and said, what are you going to do? This will be taken out of house and home. So my father said, well, maybe we can make this tiger a vegetarian. Well, we were not successful in doing that. But this is my attachment to tigers. So there we go.
Academic
this is the end of my
training
lecture.
is beyond
Robin,
compare.
maybe you can tell me how I can open this up
Chacko
for
is
questions.
widely regarded as an exceptional educator. She has worked as professor of radiology at the University of Pittsburgh and at Boston University, and currently resides in the beautiful state of Montana in the western United States, where she is chief of the hospital, chief of radiology of the hospital there. Dr. Chacko is a radiologist with an exceptional social conscience. She is very active in terms of writing, and she's had a very long and distinguished career with the United States military, and has been awarded numerous times by the military, including the Legion of Merit. I was interested to learn. We're very honored and happy to have Dr. Chacko speak to us this evening, and she's going to be speaking to us on the topic of the posterior cruciate ligament, the radiologist's view. Thank you, Dr. Chacko, and it's over to you.
Thank you very much. Can you hear me okay?
Yes, we can hear you very clearly.
Great. I was going to say good morning, but it's good evening to you. I want to correct one thing. At this point, I'm sitting at home preparing lectures for different people. I'm not working at the hospital, partly because of personal issues with my family. But it gives me great pleasure to talk to you, and I'm so grateful to Arjun for providing me with the opportunity to speak to a bunch of radiologists and also to keep my reading and learning current. We can start with the posterior cruciate ligament, and let me get used to moving the cursor around. The knee is a pretty complex joint, and it is the largest joint in the body. I would have thought it would be the hip, but it really isn't. And the problem with the knee is the body weight is carried on a very small surface area of bone, and is anatomically very complex and vulnerable to injury. Now, so the problems, if they are left unattended within the knee, they don't become easier with the passage of time. That was a quote from one of the orthopedic surgeons who trained me during my fellowship, which was last year. Now, I took on a fellowship in orthopedic and sports medicine MRI research, looking for and isolated PCL, enjoyed it thoroughly. Not isolated PCL injuries, these occurred. Analysis of the derangement of the knee represents a major part of the clinical practice of multiple medical specialties. You know, the other thing that and for us as radiologists, it is critical that we are able to appreciate what the orthopedic surgeon or the physical therapy person sees and is interested in. Now, the cruciate ligaments are our topic for today, and among the other structures are designed to protect and stabilize the joint. But because of the tremendous risks that are involved with using the knee, they're a frequent source of pathology as well as of pain, and have been used as examples. What we will start off with is evolution, and embryology, and then the function of the structure under question, and the diagnostic imaging techniques. People who jump out of planes. Now, the human being, when you compare the knee joint of the human being with other animals, we find what is absolutely different with the human being versus the animal, which is that the knee is plantigrade. The human being is a species that is plantigrade and biped. Now, what does that mean? It means that most of the animals are quadrupeds, and they also walk on the balls of their toes rather than the entire foot. Now, what that does is it places different strains on the joints involved, and the complex attributes which are associated with the human knee involve a bicondylar distal femur. We have two condyles separated by the intercondylar fossa.
We'll have the next
we are the
session
only species with intra-articular cruciate ligaments, menisci,
Thank you so much for your time, Doctor,
and collateral ligaments which are asymmetric. But here is the most important point. The greater femoral rollback of the lateral compartment produces greater strains compared with the medial compartment. Since the lateral compartment or the lateral condyle of the femur has a greater area than the medial,